Prostate cancer screening is one of the most debated topics in modern medicine. On one hand, screening can find cancers early and potentially save lives. On the other hand, it can detect cancers that would never have caused harm, leading to unnecessary anxiety and treatment. To understand why this debate continues, it helps to look at some of the most important studies that have shaped current recommendations. The largest and longest-running study is the European Randomized Study of Screening for Prostate Cancer, known as the URSPC. This trial followed more than 160,000 men for over 20 years. The results showed that regular PSA blood test screening reduced the risk of dying from prostate cancer by about 20%. In simple terms, screening does save some lives. However, the benefit is relatively modest because prostate cancer often grows slowly, and many men diagnosed with prostate cancer will never die from it. The study also found that many men needed to be screened and several cancers needed to be diagnosed to prevent a single prostate cancer death. Another important study was the CAP trial in the United Kingdom. Unlike the URSPC, which involved repeated PSA testing, the CAP trial offered men just a single invitation to have a PSA test. After 15 years of follow-up, there was only a small reduction in prostate cancer deaths and no improvement in overall survival. The trial did find more prostate cancers, especially low-risk cancers, but it did not significantly reduce the number of advanced cancers. This suggests that one-off PSA testing is not enough to produce a major benefit. One of the strongest pieces of evidence supporting screening comes from the Göteborg study in Sweden, led by Professor Jonas Hugesson. Men in this study were invited for PSA screening every 2 years and were followed for many years. The results showed a larger reduction in prostate cancer deaths than seen in some other studies. The researchers estimated that only a relatively small number of men needed to be screened to prevent one prostate cancer death. The Göteborg study demonstrated that regular, repeated screening can be more effective than occasional testing. However, finding cancer early is only part of the story. We also need to know what happens after a diagnosis. This is where the PROTECT trial becomes important. This study compared 3 approaches for men with localized prostate cancer: active monitoring, surgery, and radiotherapy. After 15 years, prostate cancer survival was excellent in all 3 groups, with more than 96% of men surviving regardless of the treatment strategy chosen. This was a very important finding because it showed that many men with localized prostate cancer have a very good prognosis. The PROTECT trial also highlighted the side effects of treatment. Men who underwent surgery experienced the highest rates of urinary leakage and erectile dysfunction, and these problems often persisted for many years. Radiotherapy caused less urinary leakage but still affected sexual function. Men on active monitoring generally maintained better quality of life initially, although some eventually required treatment. These findings remind us that the harms of treatment are real and can have a lasting impact on daily life. Because of these concerns, experts continue to question whether widespread PSA screening does more good than harm. The main problem is overdiagnosis. PSA screening often detects cancers that would never have caused symptoms or shortened a man's life. Once cancer is diagnosed, many men understandably choose treatment, even if their cancer was unlikely to become dangerous. This can expose them to side effects without providing a clear benefit. Modern MRI scans have improved the diagnostic pathway by helping doctors identify more significant cancers and reduce unnecessary biopsies. However, MRI has not completely solved the problem of overdiagnosis. Doctors still cannot reliably distinguish every harmless cancer from every aggressive one. As a result, uncertainty remains. In the United Kingdom, the National Screening Committee recently reviewed all of the available evidence. Their conclusion was that population-wide prostate cancer screening should still not be introduced because the overall balance of benefits and harms remains uncertain. While screening can reduce prostate cancer deaths to a small extent, it has not been shown to improve overall survival, and overdiagnosis remains a major concern. The committee did identify one group that appears to benefit more clearly from screening: men who carry a harmful BRCA2 gene mutation and who also have a family history of breast, ovarian, pancreatic, or prostate cancer. These men have a much higher risk of developing prostate cancer, tend to develop it at a younger age, and often have more aggressive disease. For this reason, the committee recommended targeted PSA screening every 2 years between the ages of 45 and 61 for this high-risk group. There are still important questions that need answers. For example, black men are known to have a higher risk of prostate cancer and a high risk of dying from it. Unfortunately, very few black men were included in the original screening trials, meaning the evidence is currently too limited to make firm recommendations. Large ongoing studies, including the Transform trial in the UK, are designed to address these gaps and evaluate newer screening strategies involving genetics, MRI, and advanced blood tests. So where does this leave us today? The evidence shows that PSA screening can reduce deaths from prostate cancer, particularly when performed regularly over many years. However, the benefit is relatively modest, and it comes at the cost of overdiagnosis and potential overtreatment. For men diagnosed with localized prostate cancer, survival is generally excellent, regardless of whether they choose active monitoring, surgery, or radiotherapy, but treatment side effects can significantly affect quality of life. Researchers are now working to develop smarter, more targeted screening approaches that identify aggressive cancers while avoiding unnecessary treatment of harmless disease. The hope is that future screening programs will save more lives while causing fewer harms. But for now, the debate continues.